everyone. Thank you for inviting me to speak today. I worked with Charles for many years, so we know each other well, and this is my second talk to your group, and it's a real honor, and it was really nice to go after Dr. Batchelor. I think when I was preparing for this, I was like, what should I prepare? I'm a pharmacist, but it's hard to go through the medications without going through some of the common heart conditions, and I think I was able to cut out all my heart condition slides and get right to the point with medication. So it worked out really well, I think. So I'm a pharmacist. I practice in the dialysis unit, hemodialysis unit at the Toronto General Hospital. I've been there for almost 25 years. And my specialty really is the kidney, but the kidney and heart go hand in hand. I always say the kidney is more important because there's two of them, but deep down inside, I think the heart's maybe a little bit more important. My father died of heart failure, so I got to really know and understand heart diseases. So yeah, my specialty is in dialysis, and most of my publications are to do with the kidney, but most of them are to do with medication management, and that covers, elderly people, people with heart disease, people with diabetes. So that is my specialty. So on that note, I'll get right into the next sort of 25 minutes on medications in your heart. So what I'll do is compare the different management strategies, and I'm going to focus on blood pressure and cholesterol. And then I'm going to touch upon medications for diabetes. There's two new ones they're not that new, but they've been out, and they have some really good beneficial effects on the heart. So I'll touch upon that. And then I was asked by Charles to touch upon a little bit about cancer medications and how it affects the heart. So blood pressure. So, we want it to be less than 120/80. The top number is your systolic, and this is the amount of pressure in your arteries during the contraction of the heart muscle. The diastolic is, we aim for less than 80, and that is that's the bottom number, that's the amount of pressure when the heart muscle is between the beats. Okay, so that is our goal. Dr. Batchelor went through that with everybody. And he also talked about low risk. So we really want it to be less than 120/80. Median risk is when it is between 121 to 140/80 to 89, and high risk is when it's above the 140/90. And so this really comes down to, we classify it as low risk, medium risk, high risk, so we know how and when to treat. Ray talked about how it is the number one killer. More people die of heart disease than infectious diseases. And it has an effect on every part of your body. So if you want to control, that's why it's important to control your blood pressure so that you can prevent strokes, dementia, coronary disease, and of course, kidney failure. So how do we do that? So choice of medications. So there's a lot of, after it's been diagnosed, and it's not just that one time that you go into the doctor's office, it's over a matter of time. And we are aiming for less than 120/80. And that's more recent. We didn't always aim for that low of a blood pressure, but there's more and more evidence saying that that's better for all these other outcomes, to prevent these other outcomes. So the first thing we do is we look to see if patients have anything else besides high blood pressure. And so when we do treat high blood pressure, we're treating both the high blood pressure and any other compelling indications like heart failure, for instance. If you don't have any of these compelling indications, so you're in your 50s or 60s and your blood pressure is starting to increase, the most important thing is to control that blood pressure. And so it doesn't matter which medication you use. I'm going to go through some of the different medications, but achieving the blood pressure goal is more important than the choice of drug therapy.
So Kristen, can you hold a sec? People are reporting that your voice sounds very choppy.
Oh,
I don't know if it's your headphones or...
I wonder. I'll hold my microphone closer. I don't have a very good computer. It's my work one, so I use my headphones. Hopefully that's better. Thanks for letting me know.
Yes. Thank you.
Okay. So I just want to repeat that achieving your blood pressure is more important than the choice of drug therapy. So what drugs are out there? Well, there's the simple diuretic, your water pill, which is hydrochlorothiazide. And often when I ask my students, if someone comes in with a high blood pressure, what medication would you use? And of course, this is after going through all of the lifestyle modifications, which I know you'll have a nutritionist talk about diet and nutrition, and of course, exercise is part of that as well. But after those you've achieved and you've done your best you can with the diet and exercise, we will come to medication. And so I often ask my students that, and they straight go to some of the other medications that are more common, like a ramipril or irbesartan. And I always tell them to remind themselves that water pills are cheap and they're very effective. So hydrochlorothiazide is a very good first choice. You can also use a calcium channel blocker, like such as amlodipine or Norvasc is the other name for it, and they're all good choices. Drugs from all these classes will work. So as I said, a diuretic, you don't have to use hydrochlorothiazide. You can use chlorthalidone. You can use amlodipine, but there's others such as nifedipine and diltiazem. And we're going to talk about angiotensin converting enzyme inhibitors and angiotensin receptor blockers, as these are less effective in blacks, but I'll get to this point in the next slide. So you can use things like perindopril or ramipril, irbesartan or candesartan. Sometimes we need to use combination of therapy, and that's important, especially in blacks where it's harder to control their blood pressure, or in adults where their blood pressure target is quite a bit above the target, so 20 over 10. So someone like with 150 over 90, for instance, we may want to use two different agents. We like to use agents that have their complementary modes of action. So often we'll say we'll use a diuretic with an ACE inhibitor or a calcium channel blocker like amlodipine with an ACE inhibitor. There are combination pills out there, so you're only taking one pill, and Twins does the probably most common one, and this is the amlodipine with telmisartan. In blacks with hypertension, without heart failure or chronic kidney disease, your initial treatment should be a thiazide diuretic or a calcium channel blocker, and that's because the ACEs and ARBs are less effective in blacks. They can still definitely be used, but it won't be your first choice. So I think that's really important if you are going to see your primary healthcare provider, that they do start with something like a hydrochlorothiazide or amlodipine. After those, you may want to add the ACE inhibitors. They may not be as effective, and we shouldn't be pushing the dose. So if you're on the maximum dose, then we know it's time to start another one. Pushing the dose will not actually help in a black person get the blood pressure down any further. And of course, we should never use an ACE and ARB together. And I think most people know that now. More recently, in the last 5-10 years, studies have come out to say that it's actually potentially harmful. When you do start a medication for blood pressure, it's important to have follow-up. And I think monthly is important. Even if you're going into your pharmacy to have your blood pressure measured there, I think it's very important to follow up over the first few months after starting medications. And you should speak to your pharmacist about any potential side effects. Some of the more common ones are cough from ACE inhibitors, or your family doctor should check your potassium and kidney function, especially after starting an ACE inhibitor or an angiotensin receptor blocker. One of the most common side effects of amlodipine is foot edema, where your foot swells up a bit. That can go away, but it's important that if it's bothersome, that we change your medication. What about high cholesterol? So we talked about how the LDL is your bad or your lousy one, and your HDL or your H is for healthy. So these are the types of proteins that carry cholesterol in the body, and so having healthy levels of both of these proteins is important. Too much of the LDL and too little of the HDL can cause that buildup of cholesterol in your arteries or atherosclerosis. Dr. Batchelor talked about some of the high-risk conditions that put you at a higher risk of atherosclerosis or high cholesterol levels. And so as you age, of course, if you have diabetes, hypertension, chronic kidney disease, smoking, if you've had a prior heart condition or you've had like a bypass or a stent put in, you're much higher risk for atherosclerosis or high cholesterol levels. You can have a genetic condition where you have high cholesterol. It's heterogeneous familial hypercholesteremia. It's not super common, but it's common enough that it should be tested. If you're a current smoker, we talked about. And then, of course, if you're on a statin, we're going to talk about statins, or ezetimibe, if you're on big doses and your LDL won't come down, it should be assessed again because you're very high risk of atherosclerosis and potentially an event. And of course, if you have a history of congestive heart failure. So Dr. Batchelor talked about the American Heart Association. There was a calculator We've often used the Framingham risk score. There's other ones, as Dr. Batchelor mentioned, but it's important to be able to go in and calculate your risk score. So if you do, for instance, the Framingham risk score, it too looks at age, if you have other conditions like chronic kidney disease or diabetes, and it starts to score based on your age, smoking, for instance, your LDL level. And so if your risk is very low, it would be no pharmacotherapy is necessary. So you're low risk, less than 10% of having an event in the next 10 years. There's also conditions I'll put on the right side of the slide where you should be getting a statin. So if your LDL is very high, so it's greater than 5, if you have chronic kidney disease, and most diabetics, for instance, should be on a statin. Where it gets a little bit tricky or gray is where it's primary prevention. So you've never really had an event, but your risk score is starting to get higher. So you have an intermediate risk of having an event of 10 to 19%. And your LDL is still a little bit on the higher side. Or you have some other risk factors such as men over 50, women over 60. You might have a low HDL. You might have fasting glucose levels that are a little bit impaired. So this puts you into intermediate risk, and they recommend therapy. And I'll get into that on the next slide. If you're high risk, or your risk score is greater than 20%, you should be on therapy. The reason why you calculate these risk scores is it actually helps you, or helps us to determine what drug you should get. And this is an example. So if you're low intensity and you don't need to lower your LDL too much, let's say 30%, any of these statins would work fine. So simvastatin 10, pravastatin 10 or 20, atorvastatin 10. Once your moderate intensity score goes up to 30 or 40%, 49% of lowering your LDL, then you need to use higher doses of these drugs. And if you really need a big reduction in your LDL by 50%, then you're going to use our two potent statins, which is atorvastatin and rosuvastatin, at much higher doses. These drugs work by blocking a substance in your body that needs to make cholesterol in the liver. And so it's not going to make any more cholesterol or reduced amounts of it. There are other drugs we use for controlling cholesterol. You might read about bile acid sequestrations like cholestyramine. I have not seen this used in many, many years, maybe when I first started practicing 25 years ago. But essentially binds bile acids in the gut. When it binds these acids, then the liver is telling the cholesterol, please make more bile acids. And that's how it reduces the cholesterol. So it works by reducing your LDL by about 15%, but it has a lot of drug interactions because it could bind your drugs at other drugs you're taking. So I don't really see this being often used. Fibrates, gemfibrozil, fenofibrate, it's variable in reducing your LDL. And I used to see it when I was first practicing, when our focus was to also reduce triglycerides, but we've moved away from reducing triglycerides and we will focus more on your LDL and helping to increase your HDL. It's pretty well tolerated and might cause some upset stomach. Easytrol or ezetimibe also reduces the absorption of cholesterol from your small intestine. It's pretty good at reducing LDL, and usually I see it as an add-on. When someone is on a statin, we're increasing the dose and we're still not getting a good LDL lowering, we may add this on. For someone who's had an event, like had the MI and their cholesterol is still very high, being on a higher dose of statin, we'll add this on. And then finally, there's the PCSK9 inhibitors, or repathism, the trade name for these. So these are very, very potent and effective. And it inhibits this protein that results in more of these LDL receptors. When you have more of these receptors, more LDL binds to it, and it gets taken up into the cells, and so your cholesterol is reduced. Super effective. It's an injection, usually every 2 weeks to once a month. So you may get some pain at the injection site. Again, they're not covered except for when from the Ontario government. You have to qualify. So either you've been on really high doses of statins for a long time, you've had an event, and your LDL is not coming down. And more importantly, it's used in that genetic case where you have familiar hypercholesteremia. So I too will touch upon the blood thinners, as we're seeing them more and more commonly used in practice. So what are they and who should take them? But there's different classifications. I've called them all blood thinners, but some of them work by inhibiting your platelets, and that's like a blood thinner, and others are anticoagulation. So they work in the clotting cascade and stopping some of those clotting factors from working. So antiplatelets are aspirin and clopidogrel. Those are the two more common ones we see in practice, and they're usually used, as Dr. Batchelor was saying, after you've had some type of an event. Me too. I used to always see that aspirin was used when you're in your 50s or 60s. Even the Diabetes Association used to say everyone should be on an aspirin to prevent heart attack. That's no longer part of their guidelines. So you really have to have high risk. And usually you've had an event, some type of heart event, for you to be on aspirin. And so sometimes these are used in combination. Sometimes you're using combination for a year after you've had a stent put in. But those are antiplatelets. Warfarin, and then the DOACs, which is a direct oral anticoagulant. And we're seeing more and more of those used in practice. And there's 4 of them here in Canada: Apixaban, rivaroxaban, edoxaban, and dabigatran. So I talked about the aspirin and its use along with the clopidogrel. For atrial fibrillation, so we talked about some of these rhythm abnormalities. You will often go on warfarin or one of these direct oral anticoagulants to prevent a stroke. So when your heart has these abnormal rhythms, it can throw a clot, and it can throw the clot up into the brain, which would cause a stroke. And this is why we use these agents. If you have a thrombosis, like a deep vein thrombosis, for instance, in your leg, or pulmonary embolism, we'll again use these drugs. So how to monitor? The most important thing is to look for any signs of bleeding. Dr. Batchelor talked about this. We always worry about someone, specifically if they've had an ulcer, but we want to counsel people on how important it is to look. So let's say you're shaving and you cut yourself. You may bleed a little bit longer than normal, and that's normal. But if it's any excess bleeding, you want to report that. For warfarin, we're able to monitor making sure the drug's in the right level by measuring what's called an international normalized ratio, or an INR. And there's point of care devices now where you can measure it at home. But we've moved away from using warfarin because of having to monitor the INR, as well as it does have a lot of drug interactions as well as food interactions. So now we've moved on to using the DOACs, where you don't have to monitor anything except for look for any signs of bleeding. Okay, I'd like to touch about diabetes in the heart. So having diabetes doubles your risk of any type of cardiovascular disease as well as stroke. It's important to treat your diabetes, meaning you should control those blood sugar levels. And many medications do this, and that would be a different talk. But 2 more recent medication classes have been approved to treat heart disease in people with diabetes. And those are called the GLP-1 receptor antagonists, or glucagon-like peptide 1 receptor agonist. So a few examples are liraglutide, semaglutide, and dulaglutide. Semaglutide is your Ozempic. Sodium glucose transporter 2 inhibitors, SGLT2 inhibitors, and there's 3 of them on the market in Canada: empagliflozin, dapagliflozin, and canagliflozin. So a bit about how these drugs work and some of the exciting news about them. So how do they work? What are how do they work? What do the studies show? And what are some of their side effects? So the GLP-1 agonists, such as Ozempic, have shown some pretty positive cardiovascular outcomes, and up to 10, the relative risk of reducing a heart attack, stroke, even cardiovascular death has ranged in the studies from 10 to 20%. So that's big news. And so these drugs work because GLP is a small peptide hormone that's released from your stomach cells, and they're released when you eat. And so when you eat, it binds to the GLP-1 receptor, and that acts like an incretin. And incretin actually causes insulin to be released and secreted and try to bring up glucose into the cells. It also does is slows down your gastric movement, so you feel full. And essentially, that's why some of these patients don't feel well when they take it, because they feel this fullness and they almost feel very nauseous. So that's one of its side effects. It is an injection, although semaglutide is available as an oral form as well. Usually the injection is weekly. Some of them are daily. But they do work. They reduce your sugars by about your hemoglobin A1C is reduced by about 1% or so. They reduce weight, as we all know, and they can even reduce your blood pressure slightly. So the most common side effects, this GI side effects, are this upset, gastrointestinal upset, and you may get some pain at the injection site. The worst case scenario is pancreatitis. It's not common, but there's case reports, and so we have to inform people about that. But they work, and they especially work for reducing weight, and it's important if you are obese to obviously nutrition is important risk reduction thing that you do, and same with exercise. But losing a bit of weight to help you maybe exercise more and eat better is actually a good start. But these drugs have shown benefits on cardiovascular outcomes as well. The SGLT2 inhibitors, and this is DAPA, EMPA, and CANA. And what have these studies showed? These studies have also shown to decrease the risk of major cardiovascular events in people with diabetes and heart failure. And so these drugs work by inhibiting SGLT2. So this is a receptor in your kidneys that normally would bring up glucose back into your body. By inhibiting it, you end up peeing out more of the glucose. So your sugars are reduced, or your glucose levels in your blood are reduced. They too have some side effects, and the most common one reported is yeast infections, and this is much more common in women, but men can get it as well. It can also cause urinary tract infections. And one of the more important things that we tell people is that if you're not feeling well, let's say you have a bit of a flu or a bad cold, you should call your pharmacist, because you may want to hold the medication for a few days. It can actually worsen your kidney function by taking it when you're really sick, and then it can increase the ketones in your body, which can also cause like a catabolic, or like like your acid to go up, and so you don't feel well. It worsens how you're feeling. So again, these are things that you should call your pharmacist about, to ask them about how to manage your medications when you're not feeling well. To prevent yeast infections and urinary tract infections, we tell people to drink water when they're taking this medication, and try to drink a little excess water to be able to flush things out. Okay, so those are the two medications I wanted to highlight because they're exciting. And over the last few years, we've had lots of great studies showing the benefits in reducing cardiovascular risk. And I think we'll see more of them even just being used, just not even in diabetics, but even just in patients with heart failure. So I think exciting times to come. What about cancer and heart medications? So you can have heart conditions, and I'll get into that in the next slide. And this is based on the type of chemotherapy, which I'll get into as well, and the amount of chemotherapy that you get. So sometimes it could be one or two chemo agents causing this. And so the more important thing is that a lot of times heart damage can occur even at lower doses of these drugs if you've received radiation to the chest as well. Interesting, heart problems linked to radiation therapy are less common than in the past, and that's because there's been changes in our treatment methods and doses of radiation. The young and the elder are the greatest risk for developing heart problems, with those at younger age at the time of treatment having the greatest risk, and that's just because they probably get bigger doses, more treatment because we want to save them from having cancer again, and they live longer because they're younger, and so they have more risk of having a heart condition. And people with a history of heart disease are also at greater risk of developing heart problems caused by cancer treatment. So what are some of the types of heart problems? Well, you can get abnormal heart rhythms or arrhythmias. So you can get congestive heart failure, and that's because there's damage and weakened heart muscle, which so can't pump blood out as well. You can have damaged heart valves. You can also get coronary disease, and that's from hardening or narrowing of the arteries of the heart. You can get inflammation around the heart, which is pericarditis. You can also get pericardial fibrosis, which is like a thickening or scarring of the tissue around the heart. And you can have pericardial effusion, which is a buildup of fluid around the heart. So all of this makes it very hard for the heart to pump as it normally would. And you can have carotid artery disease. So those are the narrowing of the arteries in the arteries of your neck. So I've listed a bunch of chemotherapy agents that may affect the heart. I don't work in oncology, but these are some of the more common ones, and they're used for a variety of different cancers. So what I do want to say is that when you do get one of these medications, the medical oncologist will run a battery of tests at baseline before you start any of these chemotherapy agents. And then they'll use these tests again throughout your chemotherapy treatment. It could be every 3 months or every 6 months, depending on the chemotherapy agent. And this is how they dictate if there's any changes in the heart, will dictate the chemotherapy and any changes to the chemotherapy. So they might do an ECG to check the heart rate and rhythm. They could do an echo or echocardiogram to check the muscle of the heart and how well it pumps. They could do a multi-gated acquisition scan to check the motion of the heart and how well it pumps blood to the body. They'll definitely measure all your blood tests, so for things like potassium, magnesium, just so they can have an effect on the heart rhythm. And they'll do a stress test to see how well your heart works during exercise or when your heart is actually beating a bit faster. So just a reminder that these tests will be done before you start chemo and throughout your treatment. So I think I'll leave it at that. I know I had about a half an hour, 20 minutes to 25 minutes to talk with about 5 to 10 minutes for questions. So I'm happy to take any questions. I covered a lot of different medications.
Yeah, this is excellent information for those taking medications. I don't see any questions in the chat or the Q&A. Are you going to stick around for any questions after?
No, not today. I'm sorry, I won't be able to stay today.
Okay, let me see. Yeah, I don't see any questions. That's a reflection of how good your presentation is.
Hopefully I answered lots of questions. I did cover a lot.
Sorry, Ken, there's one question that I wanted to
Sure, go ahead, Anthony.
I was wondering if you could comment on people taking medications. Very often we run into folks who say they are given a prescription, they never filled it, or they filled it, but they don't take it consistently. Yeah. Might you have a comment regarding that?
Yes.
Because it's something we see quite frequently.
It's very common, yeah. And usually after you've been diagnosed with a heart condition, it's not just one medication that you're put on. Like you're often put on, for instance, if you're diagnosed with heart failure, put on 3, 4 medications. After myocardial infarction or a heart attack, you're also put on, a number of medications, 4 or 5 different medications. So I think, again, empower yourself by understanding what they're used for. They're all used for different reasons. You might be on aspirin, to prevent any clotting. Then you might be on an ACE inhibitor, for instance. Blacks will go on it after a heart attack because it helps remodeling of the heart. You'll be put on a beta blocker like metoprolol or carbidopa, and that's used for stabilizing the oxygen demand and supply and slows down your heart. So you'll be put on all these medications because they've all shown positive outcomes to decrease, more MIs or cardiovascular mortality. And so empower yourself to understand why you're put on all these medications. And a lot of heart conditions I call are the silent killers because you don't feel that different, especially like high blood pressure. But it is important to be adherent to the medications. They work best by taking them every day. Not to say that you might sometimes forget, but it's also important to follow up with your family doctor because you might need a refill. And these are lifelong medications usually. Sometimes you can come off 1 or 2 depending on your condition and how your blood pressure is controlled, but it really is important to understand why and what they're doing. And if you have any side effects, for instance, talk to your pharmacist because sometimes there's other options. But a lot of these medications are really well tolerated. And it's just a matter of making sure you have a good routine of, when you're supposed to take them, in the morning or at bedtime, and that and that sort of helps with that adherence part of it. But you are right; it's hard to take something every day, especially if you've never been on medication. But I think if you can empower yourself, and you know why it's so important, and all the studies that have shown how beneficial they are, it might be a good reminder for yourself to ensure that you take them.
So I have a
Right.
question.
Thank you.
So on for blood pressure medication, how does it react with over-the-counter alternative drugs? Like, how can we assure that it's
So
not
always
affecting?
ask your pharmacist is what I say. Just to double check. But things like decongestants, they recommend that you don't because they can actually increase your blood pressure. Most other drugs that would increase your blood pressure, like we're taking steroids, for instance, the pharmacist should have that on profile. Often you need these other medications, so it doesn't mean you shouldn't take your blood pressure medication. So I think it's really important to always double check with the pharmacist that you're having your medications dispensed. But if you need to buy something over the counter, it's really important that you double check with the pharmacist. The other big one is NSAID, so like Advil. It can also increase your blood pressure. So I'm not saying you should never use it, but I should also say that it can cause your blood pressure to go up, and it can also cause your kidneys to decline in function. But if you're using an Advil once a month because you have a headache, it would be safe. So again, if you have questions about length of treatment and how much you can take, always double check with your pharmacist.
Okay.
It's a great question.
Yes.
Thank you.
Someone said one of the concerns is remembering the names of the meds and what they're for when you're on several meds.
Yeah. Write them down. Your pharmacist could, also produce like a little list for you. What we do for our patients is we have a little table with the name, what it's used for, and the time, and how many times a day you take it. Keep it in your wallet. It's very hard. I've been trained in 25 years of practice, and sometimes I still forget the names of certain drugs. So, especially when you're not used to it. But I think writing it down, keeping it in multiple places is really important. And again, important to show all your different healthcare providers, your dentist, the different doctors you might see, because it's really important that they see your whole list.
Okay. Thank you very much. Really do appreciate it. It's been excellent talk.
Thank you.
And always, the message I got from this is that your pharmacist is your friend.
Yes.
Please use that.
Yes, exactly. Thank you.
Thank you.